Good morning, good afternoon, and good evening. Welcome, everyone, and thank you for joining us for today's webinar presented by the Sabin Vaccine Institute. My name is Caitlin Christensen. I'm the Vice President of Vaccine Acceptance and Demand at Sabin. And today our discussion will focus on lessons learned from past outbreaks that can inform how we work to strengthen acceptance and demand for COVID-19 vaccines. Though there are, of course, a range of factors that impact vaccine acceptance and demand, today we'll focus more on exploring social structures and dynamics and their impacts. I'm very pleased to welcome three excellent panelists this morning. First, we have Dr. Jorge Benavides-Rawson, who is a physician-turned-anthropologist and is currently a PhD candidate in anthropology at the George Washington University. His current research examines the interaction of public health policymakers, scientists, and the media as co-producers of international and global policies for epidemics and pandemics. Next, we have Dr. Louisa Enria, who is assistant professor in the Department of Global Health and Development at the London School of Hygiene and Tropical Medicine. Her research combines insights from politics and anthropology to study conflict, humanitarianism, and health emergencies. And third, we have Svea Klosser, who is an anthropologist whose work focuses on vaccine delivery and acceptance, particularly vaccines provided through mass campaigns. She is associate professor in the Department of International Health at the Johns Hopkins Bloomberg School of Public Health. And currently, she's working with community health workers in Peshawar, Pakistan, to design and test strategies to improve acceptance of a polio vaccine. Our panel will be moderated by my colleague, Megan Charlton, who is a social scientist and the senior manager of vaccine acceptance at Sabin. Francesca, let's go to our next slide, please. As we get started, let me remind you that you can submit questions for our panelists using the Q&A function that's located at the bottom of your screen. We also encourage you to use the chat function now to introduce yourself to the panelists and other participants, but throughout the webinar to share comments, feedback, or interact with other participants who have also joined us today. Next slide, please. The webinar today is part of a series of programming from Sabin's Vaccine Acceptance and Demand initiative. Through this initiative, Sabin is ensuring that effective, evidence-based tools and approaches that are rooted in a deep understanding of social and behavioral drivers of vaccine uptake are used to build vaccine acceptance among communities in low and middle income countries. Our three pieces of work highlighted here explore this through a research lens by developing vaccine acceptance research agendas, exchanging and disseminated knowledge, and investing in research to further explore the drivers of acceptance and interventions that can help strengthen it, as well as by working with gatekeepers of health information, such as health workers or journalists, to strengthen their capacity to communicate about vaccines and immunization. With that, I'd like to now turn things over to my colleague, Megan Charlton, and I'll thank you again very much and hope that you enjoy today's webinar. Megan?
Thanks, Caitlin. And I also want to extend a warm welcome to our panelists for taking the time to be here with us today, as well as our audience tuning in from all over the world. As I was preparing for this webinar and just reflecting with panelists prior to starting the call, is that I was really overwhelmed with potential topics we could discuss today and really had to be selective about what we could realistically cover. So in the spirit of that, I want to jump right in, but also want to reiterate Caitlin's point to please drop questions in the Q&A, since we're going to have about a 35-40-minute discussion and then leave time for Q&A and engagement with our viewers. So I just wanted to start here diving right in with some broad reflections about global health responses to past outbreaks and really how we can better incorporate an understanding of social structures as opposed to individual level psychology and behaviors, which I think has typically been focused upon in global health, and really bring in the social sciences here in a meaningful way. And historically, despite the limitations of approaches like individual psychology and a focus on medicine and public health, there has been some attention to culture, but it's not really been looked at as a part of health and disease outbreak. Culture has often been treated as something controlled for, external to the medicine, rather than being treated as endogenous to health and individuals as co-constitutive of disease outbreaks themselves. And after all, the physical body is a vehicle for interweaving people into the world and making it possible for perception. So I'm thinking here particularly about how local communities gauge in meaning making about disease outbreaks like Ebola or Zika, giving the disease a non-scientific social life in a lot of ways, which I think very much impacts vaccination campaigns and uptake and what we're going to discuss today. And I also, we're really going to discuss a lot about the rich nuances and complexities of where outbreaks occur, including really rich historical and colonialist contexts that are not always considered in that endogenous way. And as I was preparing, I was reading a little bit from Paul Farmer's newest book on Ebola and the failure to contain it, explaining that Ebola can not only be about recent events, and I'd add it can not only be about the science, right? Pursuing health protocols and vaccine campaigns void of local complexities or in vacuums. And yet it's quite clear in the social sciences literature that social structures and disparities very much shape epidemics and responses to them. And their shaping of vaccination is no exception. So here we obviously have layers of history, violence, Western humanitarian intervention, war, past trauma, chronic illness, as all being co-constitutive of the social fabric and how people survive, really. And today we're going to dive deep into those past epidemics to show really their impact on past response efforts and vaccination efforts, and try to reflect upon what we can learn for the COVID-19 approach. But before we really dive in, I want to first take a step back, because while the panel is comprised of people from social science disciplines, I want to make sure our viewers who might be less familiar with this approach get acquainted with that. And as I was prepping for the webinar, I was really doing a lot of thinking about working as a social scientist in the global health space. And I started wondering if I had been missing any operational questions that maybe a practitioner would be better suited to answer. And as I was thinking that, I simultaneously thought that these questions about history and context and structures and inequalities, they ought to be operational questions in many ways. And the next day, Louisa and I connected about the same exact thing. So I really want to start this panel with a question for Louisa. How, in your experience, have health programs in Sierra Leone and Guinea, where you've done a lot of research, historically left out these social structures because they're not perceived as operational? And how does the global health community's narrow definition of what is an operation impact the outcome of health programs like vaccination campaigns? So over to you first, Louisa.
Yeah, thanks so much. And yeah, great reflections to open with. And I think that's a great question to start with. Maybe I'll just sort of give you briefly a bit of background, I guess, as to where I'm coming from in thinking about these things. And in particular, the experience I've had working as an anthropologist in the Ebola response in 2014 to 2016. And I was working as a social scientist based in the Ebola vaccine trials in the north of Sierra Leone, on the border between Sierra Leone and Guinea in Gambia district. And when we started operations there, we were quite lucky in the sense that there had already been quite significant lobbying, let's say, from anthropologists across the world for the significance and the importance of integrating social perspectives into the Ebola response in general, and then the vaccine trials in particular. And I think that there, what was interesting was that whilst initially these were sort of these social questions and exactly the sort of things that you point to, questions about social structure and about culture and about inequality, for example, were seen as sort of context. As soon as they started sort of becoming so obviously a problem, let's say, for implementing particular types of strategies. So I'm thinking, the example that is often given is about burial practices. So this struggle to understand local practices around death and how these were contributing to the transmission of disease sort of generated a problem that the response had to engage with. And this was clearly a social problem, or at least this was how it was conceptualized. But I think that to me is a framework that isn't particularly helpful. So it kind of turns the anthropologist into sort of firefighter, let's say, and problem solver. Which sometimes isn't particularly helpful, but also because of exactly the sort of thing that you're pointing at, which is that then we end up sort of seeing, sort of separating between what is kind of contextual or academic and what is operational in ways that kind of obscure how history, for example, is an operational question. And I think the way in which I often sort of try to explain this to colleagues across other disciplines is to think about trust. right? And so if we want to understand why, rural communities in the north of Sierra Leone may have anxieties about engaging with a vaccine trial or with an epidemic response more generally, we can't possibly understand that without understanding the history of Sierra Leone, right from, the Atlantic slave trade and the sort of memories of sort of extraction during colonialism and the Civil War and so on. So these are operational questions because they help us understand and contextualize trust and mistrust by looking at structures rather than focusing, as you say, on kind of questions of individual compliance or acceptance. I'll probably leave it there for now so we can kind of have a discussion.
Thanks, Louisa. Those are great reflections. And later on, we are going to dive a little bit deeper into trust and mistrust and actually talk a little bit about the extractive colonialist legacy with the slave trade in West Africa. So more coming on that, but I want to give Dr. Closser an opportunity to weigh in here as well for broad reflections, opening this up. Generally, how do you feel that historical outbreaks and vaccination campaigns in Pakistan demonstrate to us that we need to better steep global health programming in these socio-political, historical, colonial contexts? And then maybe practically speaking, how do we go about translating these insights real time? We're dealing with COVID-19 right now. Rapid ethnography, which I know Louisa is also familiar with, comes to mind. How do we practically speaking do this?
Yeah, thank you. And thanks, Louisa, for those great comments, which I think I'll just sort of build on and then think a little bit about what practically can be done. The way that I think about this goes back to some foundational medical anthropologists like George Foster and Judith Justice, and thinking about the fact that in any health intervention, when you talk about social structure and culture, it's not just the social structure and culture of the recipient community that's at play. The health system also has a social structure and culture. And when you talk about trust, there's two groups, I guess, at least, often more, but at least two groups that have to trust each other, the community and the health system. And a lot of times when we talk about social structure or culture in accepting vaccines, the focus tends to be on the recipient population. And there's a lot of reasons for that. A lot of times it's easier to think about the recipient population as the group that needs to change. Often the health system doesn't like to think of themselves as a group that might have a problematic hand in maybe the trust relationship. So yeah, that's kind of the way I think about it. And, if you look at something like the polio program in Pakistan, currently undergoing a lot of problems with vaccine hesitancy and active opposition, which are sort of two different issues. But it has a lot to do with particular populations' trust of the government, which doesn't come from nowhere, right? It comes from history. But it also means that there's two ways to sort of shift the dynamic. One is to try to convince recipient populations that somehow they're wrong not to trust this entity and that the vaccine is actually safe. Perfectly reasonable thing to try to do, but if there's really good reasons that they're mistrusting the entity providing the vaccine, that may not shift a whole lot. And you don't have to look to Pakistan to find that. You can find that right here in Baltimore where I work, right? The institution I work for, Johns Hopkins University, really problematic history with the populations that surround it. And that trust relationship is tricky. And it's not just about people living in Baltimore, it's also about the institution of Johns Hopkins, right? So anytime you've got this, it's about the institution. So I guess what I would say is one really promising way forward, and something that has proven pretty effective in the polio program, is to think about what do people need from this institution that they're not getting, and can actual shifts be made there as a way to really build long-term accountability and trust. And then, vaccine acceptance is something that will follow from that. So you see that in terms of, in the polio program, providing broader services that people really want and haven't been getting, rather than just focusing on one vaccine for polio. And I think there's obvious relevance there to COVID, in the sense that if you're just providing COVID vaccine and nothing else that a particular population needs, that's going to have implications on the trust relationship.
Yeah, thank you, Dr. Closser. And my next question for you is about structure and the way that's impacted vaccination programs. So That's coming up. But I want to give Dr. Benavides-Rawson a chance to weigh in here as well, based on your fieldwork in Costa Rica, as well as with Ebola response.
First of all, thank you for inviting me. It's great to listen to great panelists. I wholeheartely agree with Dr. Closer, particularly on the attention we need to put on the healthcare system as a cultural actor and a site of cultural production. And the way I look at this, there's the recipients, there are the institutions such as the healthcare system, and then there are the policies. And they sometimes work together, but often not, and they don't often come from the same place. So, for example, in developing countries, policies might not come from them, but they might come from bigger institutions like the Pan American Health Organization, for example. And this is what I saw in my field work, for example, with dengue and then with Zika. So PAHO would make policies that I expected to sort of trickle down. But when you see them, they talk about the clothing you wear and the repellents and a lot of things that sound very tone deaf in terms of specific community that you're going to work with in terms of their economic access. But then there's also the cultural part, the understanding that the daily work that they do, how they need to interact with the environment, and whether or not they can engage with preventive practices such as closing the windows and getting rid of water collection sites. And then the healthcare institutions, they have a historical place in the cultural imaginarium of different places. In Costa Rica, for example, the healthcare system has been there since the 1940s. And there are a lot of criticisms in the population about efficiency and other stuff, but in terms of trust, it's very solid. It's seen as an institution that does not mean to harm. So we did a survey a few months ago on vaccine acceptance for COVID, and 86% of people said they would take it, which is a reflection on that relationship. But on the other hand, there's the risk perceptions of diseases that we see. There's a difference there in which maybe a specific locality might see a disease not as important as other things. And we saw that in Zika, where in my interviews, people say, yeah, I know Zika and dengue are important, but I'm more worried about, my next door neighbor where I live, because there's a lot of drug use and I'm worried they're just gonna, come and kill me, or, I'm worried about unemployment. So wherever they place diseases in their rank of risk is related to cultural, economic, and environmental factors. And that needs to be computed in the way we think about how to promote, prevention programs.
Thanks, Dr. Benavides-Rawson. You're also foreshadowing a large question of mine about prioritization of different health issues, which we're going to come to. But I want to stay on this topic of structures because it is my next question, and you've all brought it up here. And I think in many ways, each of you importantly shifts a focus away from individual level responsibility when it comes to vaccinating, to instead look at these healthcare structures and social structures, and really the internal workings of aid organizations and healthcare workers. And Dr. Closer, I just wanted to give a brief overview of the puzzle you present in your book, which I first read as a bright-eyed grad student, and I read again this weekend. But you ask a really large question here, right? Why might the polio eradication initiative fail in Pakistan? And you're telling us it's not what we might expect, right? We might expect that it's because aid organizations and workers are illiterate in local cultures and fail to understand local dynamics. But actually, you tell us it's the structure of the polio initiative itself. And you talk a lot about power dynamics and the messy internal politics of organizations at multiple levels. So multilateral, like WHO, at the nation state level, power dynamics there, and then at the district level, health governance, exploring how power and resistance very much inform success of that polio initiative. And I think this is a very different example than where we see what's happening with Ebola response. And I'm going to bring Louisa in here as well. But I just wanted to say that I find that this is a very important turn in the scholarship and a call to action for the aid community to self-reflect and better understand what it's doing in its own operations and how that impacts vaccine delivery. So Dr. Closer, first over to you. I was hoping you could expand a little bit upon why this focus on structural and organizational components is important in vaccination campaigns, You talk a lot in your book about the structure of the Pakistan polio campaigns, particularly how they were mass campaigns for about 8 times a year, a week at a time, which allowed officials from Geneva and Islamabad to always be present. And I think there's also something to be said here about the patterned interactions of aid workers with the same community that allows them to have that rich knowledge of the context that we might not always see studying comparative aid, as I've done myself, that's not something we see. We see people parachuting in and out of context, lacking that local knowledge. And I think we see it happening with Ebola too. So I was curious if you could expand a little bit more upon this important contribution.
Well, yeah, thanks. I mean, the polio story in Pakistan is a really interesting one and revealing when it comes to vaccine acceptance. So when I did my fieldwork for that book, I was in grad school, it was 2007. And at that point, vaccine acceptance for polio vaccine was not a big issue in Pakistan. There were a few people that were vaccine hesitant, but in general, the rates of that were very low. And that has changed. There's been a huge change in that in the last 10 or 15 years. And vaccine hesitancy is now a real problem for the polio program in Pakistan in the way that it was not before. So I think this is really revealing when you think about what causes vaccine hesitancy, right? This is one prime example where it's not something that existed in, like, I don't know, whatever you want to call it, Pakistani culture or Pathan culture, or you can go down to like ethnic groups below that. This isn't the cultural thing. It's a reaction to something that came out of the polio program. And I want to make clear here that the polio program in Pakistan is world-class. The people who run it are extraordinarily smart. They work very, very hard, and they have a very good understanding of what's going on the ground. So anything that you can talk about the polio program's difficulties, it's not because they don't have fantastic, fantastic people, because they really do. I mean, I'm in awe of these people. But what's happened is that there's been a huge amount of pressure from the international level in particular to focus on this one disease. And this is probably likely to come down the pike with COVID again too, right? There's going to be a huge amount of pressure for countries to control COVID. In the case of Pakistan, it's one of the last countries that still has endemic polio. So there's a huge amount of pressure for them to focus on this as their priority number one. Just as there's likely going to be pressure to focus on COVID as priority number one. That, of course, pressure comes from someplace like Geneva, from Seattle, from Atlanta, you know, wherever you want to say that these decisions get made. And it gets in, you know, there's different feelings about how much priority should be put on that disease at different levels of the health system. And that really affects how it plays out, how happy people are about it, how motivated they feel. And a lot of times people's, you know, a district level health manager in rural Pakistan may have excellent reasons not to feel like polio is their number one priority. Of course, it has to be if we're going to eradicate globally. So there's, I guess this is a very long way of saying that, you know, in any program, and this is going to be the case with COVID, there are going to be people who have very, very good reasons not to make this priority number one. And the harder that international organizations push, the more complicated the relationship with the local health agencies and with recipient populations becomes. And over time in Pakistan, what this has led to is deep, deep resentments and opposition to the polio program by local communities who did not start out being oppositional. And it's not so much about the vaccine per se, it's about the push and focus on a disease that's not a priority for them. So.
Yeah, thank you, Dr. Klusser. We're going to circle back to prioritization of health issues too. But before turning to that, I wanted to bring in Dr. Enria here as well to give you a chance to weigh in on the situation with Ebola, since I do think it's a little bit different what we've seen in terms of international response, for example, and lack of local knowledge, particularly thinking about the DRC, where we have a host of different international actors in here, from peacekeepers to Red Cross, Red Crescent to WHO, et cetera, I could go on. And they're very much all impacting, I think, aid delivery there, but also these pattern interactions with different aid organizations very much looms large in the mind of people who are in those communities. And we haven't seen the aid community necessarily have that depth of knowledge that Dr. Closser is talking about in the polio case. And you mentioned earlier burial rituals and the perception of sterile body bags and things like this. So could you speak a little bit to the Ebola emergency and how we see this difference, but also any structural differences compared to Pakistan?
Yeah, thanks so much. I mean, this has given me a lot to think about. I mean, I couldn't agree more about the fact that there is often this perception. I felt that very strongly in the Ebola response, at least at the beginning. Also, because I should say, I think these responses are so dynamic that they change even, within the initial 4 years of the Ebola response. We saw a massive shift in kind of perception. But in terms of, understanding that it's not just people who have culture. So culture, not just that culture is not a barrier in itself, or culture is not something that exists that's necessarily sort of prior to the intervention, is also constructed by the intervention. But also that the intervention itself, so the kind of, assemblage of different actors that were involved in the Ebola response had their own culture. And it made it so much more complex by the fact that it was so many different actors. And so having kind of different NGOs, different international organizations from different countries with different priorities, different operational requirements, then, national level actors, which had, again, their own kind of operational requirements, but also their own kind of situation within kind of a political and economic history of Sierra Leone as well. I mean, I focus on Sierra Leone, that's the context I know in terms of the Ebola response. And then you have sort of local structures and power structures within communities as well, because we often sort of think of community as homogenous, but of course it's much more complex than that. So I think that's sort of an important thing to recognize, and also within that sort of recognizing how sort of local or how communities are then kind of conceptualized and constructed and acted upon. And actually what, this discussion just now about the fact, that there wasn't vaccine hesitancy before, not as much, I think is fascinating, because you could say something. So, I mean, Sierra Leone hadn't experienced Ebola before, so there wasn't, or at least it hadn't been detected. So it's not like there was a kind of an already available format to sort of think about for communities how to respond to the response. And so to some extent, this image of sort of communities, as in a pre-existing culture in which a response intervenes in, wasn't just kind of conceptually wrong. It also sort of hindered an effective response to a large extent. And so I sort of saw this most so if we're thinking about kind of structural questions, I saw this happening the most in terms of engaging with local authority structures. So there were a huge amount of assumptions about who had power in specific communities and who should be engaged first, for example. So you'd have all these sort of pre-engagement protocols of different organizations going in to engage communities through chiefs, for example, which, who certainly are trusted and respected in certain areas, but very much not in others. And that's, something that's sort of constantly evolving. But also, recognizing the fact that in so doing, the response is creating those power structures and is redistributing power within communities as well. So I think, certainly a sort of different kind of response, but I think similar questions coming up there. And I think maybe only the last sort of small thing I want to say in relation to that is this question of, how we kind of think about in the context of an epidemic, for example, how we think about vaccine hesitancy or confidence as being not necessarily about the vaccine itself, as Dr. Closser was saying. I think that's really important to recognize, and that's something that's come up over and over again in our work, both during Ebola and after Ebola, and more recently, in terms of how broader experiences of interactions with the health sector at the district level, for example, or international actors have a huge impact on kind of confidence going forward. So it's not something that's already there necessarily.
Yeah, thanks, Louisa. And I think that's an incredibly important point, that the vaccine is not necessarily about the vaccine itself. So I'm definitely taking notes myself here too. But mindful of time, we're already 30 minutes in, and I want to make sure we keep plugging along. And I'm going to do some prioritization here of my own questions, and really want to make time to talk about priority setting, which we've all touched upon here, but I want to dive a little deeper into. I think this is an incredibly important moment for us to be talking about this as the WHO strategizes vaccine rollout through COVAX as national and local level development plans are being strategized as well. And when I was thinking through priority setting, I was reminded a lot about COVID-19 prioritization and in context that admittedly COVID-19 has not been a health priority. I'm thinking specifically about Rwanda, where contact tracing by community health workers has very much succeeded. But then looking historically, as Louisa's talked about with Ebola, making Ebola a priority in a country like the DRC, where they've been dealing with decades of conflict and where protection and security might come before the what many people might consider a foreign virus, that it wasn't there before interveners came in. And obviously DRC is one of the longest ongoing humanitarian crises now. But then Dr. Closser, you're also mentioning how polio is just simply not a ranking health issue for local communities. And Dr. Benavides-Rawson, you're mentioning this about Zika and dengue fever as well. Obviously, I'm thinking here about more important material concerns like food on the table, addressing poverty, having shelter that might come first. My background's in emergency response and displacement settings, and I certainly see that come to the forefront when vaccination programs have tried to be prioritized over meeting these more urgent health concerns or basic needs, really. And Dr. Closser, in your book, you talk a little bit about the international community's culture of optimism. And I was wondering if you could start with some reflections about what this means for priority setting and political feasibility and things like this when it comes to creating vaccination campaigns in communities where this just simply is not a priority for the communities themselves.
Yeah, I mean, I think, you know, in terms of thinking about something like a COVID vaccine rollout, right? I think the starting assumption should be that it's going to be a priority in some communities and not in others, rather than having the starting assumption be it'll be a priority for everyone if we show them how important it is and show them that it should be their priority, right? That's a different starting point than the starting point of we're going to assume that it's not going to be priority for some communities, and secondly, that there's good reasons why it may not be a priority for those communities. So it's not just a matter of convincing them that it should be their priority, but figuring out what those priorities are and how something like a COVID vaccination might fit into those priorities, right? Yeah.
Yeah, thanks, Dr. Closser. I would entirely agree with that. And I want to bring in Dr. Benavides-Rawson here as well, looking at Ebola, but also at your historic work with Nicaraguan migrant populations in Costa Rica. If you could speak a little bit about priority setting here, specifically with migrant populations as well.
Thank you. I think one thing we disagree a lot of anthropologists. One thing we all agree on is that notion of one size fits all. It's completely wrong, right? We really like to focus on the local and how people perceive things. So the first problem with priority setting is sometimes that it's done in a larger scope than it should. I mean, geographically or culturally, priorities for a continent or even for a country like the United States, it fails to see the way, the nuances where the way you have to work with individual communities. For example, in some places, contact tracing will be easy. Latin Americans have a history of understanding that the healthcare system tracks their information. So doing that there early will work. And you can put that as one of the first ways to start controlling. In other places, that if you start with that, all you're going to get is a pushback from the community. So maybe you put that further back in your arsenal, what the things you're going to do for the vaccine. And also in terms of the different communities within the place. So you mentioned the migrant workers from Nicaragua, which is a community work within the border of Costa Rica and Nicaragua. It's a community that changes a lot. There's a percentage of people that always stay, but there's a percentage that fluctuates. So focusing on that, focusing then more, for example, the infrastructure of the place where people are going to live could be a priority. You have to look first into more than the specific people, because the specific people might change. So we have to not fall in that error of thinking that what worked one place works in another, or even what worked last year here might not work this year or next year, because that particular community have changed or perceptions have changed. about something, and that also includes things that I agree with what Dr. Enria said about the vaccine, and not being about the vaccine. Sometimes reactions to certain policies are proxies for something else. You know, a lot of the reaction in the United States against the vaccine follows the reaction against the masks. So they are really proxies for a different type of cultural and political, discussion happening in society.
Yeah, thank you, Dr. Benavides-Rawson. Those are really important points, more to think about there. I want to bring in Dr. Enria here as well, and I'm going to ask you a slight variant of this question, and I think a tough question. When we talk about vaccination programs, we often talk about engaging local communities, centering local voices, and we talk a lot about partnership. And I think that what we're talking about here is prioritization, that the international community has prioritized vaccination in many ways when it's simply not a material need in many communities. How do we go about engaging with and partnering with local communities when it's simply not a priority for those communities?
Yeah, thanks. I mean, this question of prioritization is something that's been on my mind a lot recently. I just come back from Sierra Leone over the last month, and it was quite an interesting, I mean, from a personal level, quite an interesting shift, moving from Europe, where obviously COVID is all we think about and talk about, and then going to a place where it isn't, well, it isn't a priority at the community level. It certainly is a priority for the government. And so, kind of asking that question of, who decides what's an emergency, who's an emergency for who, especially as the other panelists have said, in context where, somebody might say, we've had Ebola here, we have, very high maternal mortality, for example, how do we decide what's an emergency, what's a priority? Having said that, I do think that there are also sort of complex kind of equity and justice questions about kind of, access to a COVID vaccine. And I also think that there is, we know so little about where this is going next, right? Especially, in West Africa, for example. And so one of the things that we'd started doing, and it's by no means perfect, but I think has been interesting in a way that I hadn't sort of anticipated, and that's my own kind of blind spot. But we've started having some discussions at community level, so doing some research about vaccine deployment strategies. And so doing, for example, scenario-based discussions about, comparing an Ebola-like scenario and a COVID-like scenario, and kind of thinking about people's kind of perception of risk and kind of willingness to take a vaccine, for example. And that threw up some really sort of interesting discussions about prioritization, but also, about kind of risk perceptions and so on. So I think, I don't know, maybe this is too simple a solution to a tough answer, but I do feel like often, and I would say this as a social scientist, but I do think that often sort of talking to people about these questions is kind of a good starting point, and we don't do it often enough. And I think that my sense would be that actually people have a very kind of sophisticated way to think about risk and about prioritization, and that's dynamic and it changes over time and with different types of information. And I think that isn't often enough the starting point of interventions, I think.
Thanks, Dr. Enria. I think that's a really important point as well, but agreed that we really need to focus on local perceptions and starting there. And I would add probably beginning vaccine programming design with that, which is not always the case, right? Mindful of time, want to leave time for Q&A, but also want to have a discussion briefly about memory and trust, which I think is really important in all of these contexts. Just briefly, we've talked about patterned interactions with a host of foreign interveners and organizations, and the way that it can very much impact ongoing vaccination programs and COVID-19. But then also, for example, war and trauma have such a heavy history, right? Omar Dawachi talks about therapeutic geographies and the way that it reorganizes healthcare under conditions of war, and medicine being co-opted by the state and used as a weapon of the state. So I think in so many ways, a memory and trust really loom large in the minds of individuals in all of these contexts, with Ebola, with Zika, with polio vaccines as well. And I know you've all touched a little bit upon that here, but I want to start with a question to Dr. Closser. I've been doing a lot of thinking about trust dynamics between local communities and international aid campaigns. And oftentimes we talk about trust building with local communities, but I really think we might want to ask ourselves, how can we be more trustworthy as aid individuals ourselves? And so I want to sort of flip the switch here and talk about that dynamic instead, and was hoping you could offer some remarks about that.
Yeah, absolutely. Yeah, so when it comes to trusting international organizations in some place like Peshawar, Pakistan, where I'm working with some other people currently, there's clear, obvious historical reasons why you would, you don't have to go very far back in history. You've got the fake vaccination campaign that the CIA did to find bin Laden, an obvious example of an egregious breach of trust in institutions, right? And, not even that, you've got something like the US government doing very disparate things at the same time. On one hand, heavily funding polio vaccination programs, on the other hand, also heavily funding drone strikes in the very same communities, right? I don't want to make this all about the US. The US is not the only actor involved here and not the only one that has trust issues for very good reasons, but it's an obvious example, right? So then when it comes to building trust, the question becomes more not just speaking broadly, I as the, American face of the polio program, right? It's not just that I need to convince people to trust me. I need to acknowledge that there are very, very real reasons people may not trust me, and think about ways that I could demonstrate that I'm listening and that I care, and that may not be enough, but it's the only way through, right? Yeah, so not just asking people what they want, that's a first step, but then actually providing it would be another step. And understanding that my desire to have people take the polio vaccine or the COVID vaccine is coming from my professional aspirations too, and that I have a dog in this fight, and that I care for reasons that may not just be altruistic, right? Pretty much anybody who's staked their career on providing vaccinations has a professional interest in this as well. And so then coming to it from almost a negotiation, here's something I want, here's something you want. Let's see if we can work together to come to something that, might be workable for everybody involved. But not trying to hide the fact or work around or pretend that those deep trust issues aren't real and that they're not well-founded.
Yeah, thank you, Dr. Kosser. And really important point that you make here about not just focusing on the international community, but also on national level and local level politics as well. So we've certainly seen this in West Africa with nation leaders being much more concerned about exporting Ebola to the West than taking care of their own populations. So I actually wanted to bring in, before we turn to Q&A, Dr. Enria here to talk a little bit about trust dynamics and memory in West Africa. We know that the Ebola outbreak was original in the 16th century, was an original site of slave raiding wars. So I want to talk a little bit about memory and trust here as patterned, but also, of course, knowing that their own heads of state have oftentimes not prioritized and marginalized certain populations for care.
Yeah, I think that's a really important way to sort of frame it, to think about it in all of these dimensions. What struck me as really sort of powerful, I guess, at the beginning of the outbreak and throughout really was kind of listening and understanding sort of rumors and anxieties that were circulating about Ebola, and sort of, and some of them weren't particularly hard to interpret in this lens of, historical mistrust, right? So if we think about, the most prominent rumors about things like, Ebola is a Western ploy to decimate the population, or, or for example, those directly related to the vaccine trial that I was working on, rumors about blood theft and blood being stolen to be taken abroad, which we could also have a whole other discussion about, kind of blood samples being shipped elsewhere for scientific research. But very sort of specifically in terms of how we interpret this, in a context where it isn't entirely unlikely to have those kinds of opinions, and they are based on sort of memories that live through the centuries, even if not in sort of people's sort of direct consciousness, but certainly in terms of embodied experience. And so being able to kind of understand how those anxieties aren't just to be debunked or dismissed as misinformation, but are actually sort of really fundamentally rooted in this history of sort of well-founded mistrust. And that's, so sort of at the international level for sure. And then I think it is also, as you've both said, important to think about kind of relationship to national level and more kind of immediate histories of exclusion and marginalization, both, in West Africa during the Civil War, but even more recently, in terms of or sort of uneven development across the country, for example. And I think this question of, listening and also responding to what somebody has told you that Dr. Klosser has talked about, I think is really, really important. And it's, we ran a discussion recently between nurses, community health workers, and communities where everybody was sort of encouraged to put everything on the table and sort of say, for example, the community talking about how they felt that they hadn't had their services provided, and nurses talking about the fact that they hadn't been paid, for example, right? So really sort of basic things that ultimately, even if you can't sort of immediately change the structural conditions, actually sort of show respect and dialogue and a way of sort of trying to start chipping away at some of those kind of experiences and make people feel like they're being listened to and that their mistrust is understood and not seen as kind of ignorance or lack of understanding.
Yeah, thanks, Dr. Enria. On that same note, I'm going to turn to Q&A questions since many of them are about trust. And I'm going to send this over to Dr. Benavides-Rawson first. Someone from our audience has asked, how do we handle news from the outside? So external news reporting, for example, of a nurse collapsing who's had a vaccine shot. We don't know if it's directly tied to the COVID-19 vaccine. How do we handle communication and trust around adverse side effects?
Thanks for that, because a lot of the things I'm focusing on is media, the role of media. And I address this from the side of science and technology studies about knowledge production. So we tend to look at the policymakers and the scientists as the people who produce knowledge about pandemics. And we think of media as sort of like vehicles, but actually media and journalists are producing knowledge and are producing understanding in the communities about the pandemics. And so the way that specific news that are outliers are portrayed as central to issues, for example, a rare reaction to a vaccine becomes sort of like the vaccines cause reactions like this. There's a discussion there to be had about journalistic ethics, but also in the dialogue between the policymakers and the hospitals and the journalists. Often the information I've learned that happens between the transfer information between, say, a hospital and the news media happens through a journalist that works for the hospital. So every hospital and university, they have their own press people. And sometimes they're not thinking ahead of time, I think, of how the particular headline might sound later on, or trying to make sure that it comes out in a way. So, something as simple as saying, in a rare situation, this person had a reaction to this vaccine, just adding that to the title, because you also know that the majority of people would read the headline and not the whole story. So even if the story clarifies the information, that's not going to be transmitted to the majority of people. So it is hard to find a way to push to fix this without gaining into affecting, the freedom of press, for example. But areas that we can tackle on is, for example, that relationship between press officers and institutions and the journalists that contact them. That's a place where you can create sort of like best practices in terms of how you transmit the information in a way that will not contribute to mis or disinformation.
Thank you for those reflections, Dr. Benavides-Rawson. We have another question that's coming in, then I'm going to send over to Dr. Klosser. Someone from the audience asked, does anyone have a view as to whether or not groups in Geneva, Seattle, or Atlanta have a growing awareness of the trust, risk, and prioritization issues? Is there any evidence that they may be incorporating this into their programming?
Great question. Very complicated question. So I'll give my I haven't done research on this one, so this is my unformed answer. This would be one to do some interviews with those communities to find out where they're at. My initial feeling is that, yes, they are aware of these things. They also have powerful structural forces. Everyone in those organizations has powerful structural forces that push against their ability to take those awarenesses into consideration on a daily basis. They've got very intense political attention. They've got intense targets to reach around something like COVID control. And that pressure, right? I mean, this is sort of another lesson from the polio program, that pressure on those officials, right, to eliminate this disease and focus on this disease, and your whole career is now all about what you do about this disease. It puts you in a position where it's hard to open up the space for some of these conversations. So I would say that my sort of guesstimate answer to this question is that yes, these people are very aware of those things, and that the way that politics around these diseases play out is that they may not always be able to act on that awareness.
Thanks, Dr. Klosser. Mindful that many of our audience is on the inside of this as well, so great reflections. Dr. Enria, I want to send this question over to you. It's also a very large question, might ask you to project a little bit. Someone asks, I wonder if someone on the panel might be able to comment on the ethics of addressing the depolitization of COVID-19 vaccines. How do we implement vaccine interventions in a way that genuinely takes into consideration different skepticisms of communities?
Yeah, great question. It's so I'm a political anthropologist by training or sort of initially, and I've been really interested over the last year to sort of keep hearing these calls across the, from all sides to sort of depoliticize their response. And I understand, of course, what they're getting at, but to me, I guess it's hard to understand how you would do that, because it seems to me like it's a fundamentally political question. So it actually seems to me like these calls to depoliticize are problematic, because they're exactly sort of obscuring, how we actually engage with political questions, right? And the fact that we just absolutely have to. And I think that those are sort of political questions at different levels, right? So in a sense, there are some that are easier, some that are harder, but I think probably not many have been done so far, at least in my view. I mean, you've got the sort of like really big political questions about sort of vaccine nationalism and in different kind of institutional regimes sort of dealing with the vaccine question in very different ways. But I think if I sort of understand the question correctly, it's more about sort of the political relationship between states and citizens in this particular question. And I think that there, maybe it also kind of goes back to what we've all been talking about so far in terms of how do we kind of conceptualize the role of, let's say, the kind of the population that is to be vaccinated, and what, how do we kind of take into account their views? How do we sort of try to understand potential sort of sources of hesitancy, not in the community or in the individual, but in how trustworthy the vaccination program is. But I think I sort of saw a question in the chat that makes me think, there's also a challenge of, we can kind of discuss why that's important, but I think the really much bigger challenge is how do you make sure that the actors that we're implicating in this discussion are actually the ones that have to act on it. So that question of, how do you actually institutionalize these responses? How do you ensure that the right people are operationalizing these questions, I think is a really challenging question, and something that there isn't, I don't think it's about not knowing that these issues are important. I think it's about kind of political denial, or kind of not an interest in engaging with this, which is a really challenging political issue.
I think that's a quite important point here, and would echo that all sides are calling for depolitization in a way that it's deeply political and not possible. Thank you to everyone who participated in the Q&A and to the wonderful responses from our panelists. I want to end with my own question, which I think is a useful way to end this webinar. We've talked a lot about a lot of different things today, including priority setting, the role of memory and trust, the role of past foreign interventions, national level, regional level dynamics. And the role that social science really brings into this global health programming and how and when we can plug it into global health programming. So I want to end with one question for each of you to respond to ask you for concrete recommendations you would give to individuals at the international, national, and district levels as we're rolling out COVID-19 vaccines. And I'm going to start with Dr. Benavides-Rawson here. You're on mute.
Sorry, yeah.
That's okay.
So first thing, when I write a book about this time, the title of it is going to be "You're Muted." And number two, I heard half your question. So could you repeat it?
Sure. So I was just looking for your reflections on concrete recommendations we could give to individuals at the international, national, and district level health operations as there's strategies going on right now, working on COVID-19 vaccine rollout. Any reflections from you on concrete recommendations you would want our viewers to take forward?
Thank you. That's great. And I think first is make the communities participants in the process of policy making and program making, right? That, this is something that in public health literature has been there for a while, but it never really happens. We talk about empowering communities, making them own the program, but in the design of the program, it doesn't work when you come with a program design and then you tell people, oh, we're going to give this to you and now you own it. But to create it, because the priority setting comes from the community, and you have to, one thing we've learned as anthropologists is to contact key people in communities, religious leader, the local, political figure, people who already have a level of social capital in that community, and work with them rather than against them, right? Don't compete with people, rather work with people. Or, Dr. Farmer talks about walking with the community. The other one, more, making ask for ourselves, social scientists, is include social scientists more earlier in the development of programs. It often happens that we're contacted to answer questions once a program's been going on for a year and something didn't work. I'm not saying we're going to fix everything, but maybe a lot of things could be solved if people not only with medical or biomedical or epidemiological knowledge are included, but also people with social science knowledge. After all, diseases are, yes, about the agents, but they are about the people, right? They are about social networks and social interactions. So including social scientists early on, as well as community leaders, I think it's one of the simplest way to try to do it. It's not concrete, but it's going to make those policies, I guess, better adjusted to the particular situation of a community and a particular disease.
Thank you for those reflections. That ties back to one of Dr. Enria's first points about anthropologists and other social scientists being treated as firefighters, right? That we're not engaged at that design stage, and instead we're putting out fires once they occur. On that note, Dr. Enria, any last reflections and concrete recommendations?
I mean, first, I definitely want to vote also for Dr. Benavides-Rawson's comments, because I think that's certainly one that I would agree with. I guess sort of on top of that, I would say what's really important is to diversify communication and community engagement. So not everybody stands in the same relation to the vaccine and to the vaccination program. So we need to kind of understand people's different experiences, communities, different groups within societies. And within that, also kind of linking up to this question of social science expertise. So to also diversify what counts as expertise and what kind of who sits on, in the UK would be SAGE panels, but, expert panels in terms of, what kind of evidence kind of guides vaccination programs. And then I guess the only other thing, as we've been talking, to sort of treat trust as a political, not just a technical issue. And I think that links up to kind of understanding different groups and different communities' needs and their need for different types of information.
I like that, treat trust as a political issue and not just a technical issue. I'm going to turn over to you last, Dr. Klosser.
Well, thanks. Yeah, I couldn't agree more with my colleagues. All the things that they said, absolutely. And just pulling on a couple of really interesting questions in the chat about, Robert Steinglass's question about how do we change this? Great question. Another great question in the chat about, what does this mean given that a lot of this is going to be implemented through routine immunization structures in some way or other, in various countries. So I've got a couple thoughts sort of going along the very same lines of what's been said. The first thing is that vaccine delivery cannot be depoliticized. It is political. It's delivered by political entities to people with political structures. And so taking that seriously, and again, I would reiterate that taking it seriously from the outset and not once you already have a problem, and then it's a little bit, it's harder to fix the issues once they have become entrenched than it is to think about them at the outset and think about how you might not eliminate them, but maybe work with them a little bit. Yeah, and given that, this question about given that, people are already receiving vaccines in many cases through certain systems, understanding what the politics of those systems are as they exist will give you a head start on understanding what kinds of things might arise as they go forward. Simpler in a place with a very simple delivery system, harder in a place like the US, which, even in my hometown of Baltimore, it's really difficult to even understand who all the actors are sometimes. Yeah, but thinking through these things at the outset, taking them seriously at the outset, and including these considerations along with the technical considerations, yeah, and not thinking that they will ever go away, because the vaccines will be political. They always will be, but we can work with those politics.
I think that's a great note to end this webinar on. And I just wanted to say thank you for everyone joining us around the world today, and a special thanks to our panelists. But I also want to say a huge thanks to the team running this that are not on screens right now. Jamie, Cassidy, and Francesca really could not have done this without you. And really appreciate your support. And to all of our viewers, we wish you safety and well-being in really unprecedented times. And thank you again for joining us today. I hope you have a good day, evening.
Thanks.
Thank you.